Okay, so should we start? Otherwise we'll be late. So the way we run this, we thought to try and give us some time to do the questions. What we're planning on doing is doing the talks in groups of 4. So we're going to do the first 4 talks without interruption, and then we'll take some questions at the end. We'll run straight through. So the first talk will be Nick Beresford on reducing infection. Then we'll do Debashi Das on minimizing the need for HDU in adolescent idiopathic scoliosis. Then George McKay, VBT. Then Akash Daya on enhanced recovery. Then we'll stop and do the questions. I don't have a bar to start the talks.
I'll start it then, Neil, if that's...
Is that all right, Lee? Sorry, there's used to be a bar at the top, isn't there? I can't see any of it. We'll do the 4 run-through then, Lee.
Hello there. My name's Nick Beresford-Cleary. I'm currently a spine fellow in Vancouver, Canada, and I'm here to report some work that I did whilst a fellow in Oxford, UK, on reducing surgical site infection in complex paediatric spinal surgery through the use of an infection bundle. So surgical site infection represents around 20% of all healthcare-associated infection for hospital inpatients in the UK. And it's associated with an increase in patient morbidity, mortality, length of stay, and places a significant financial burden on the NHS. Published rates of SSI in paediatric scoliosis vary quite considerably, but range up to around 22%. So this is a big problem. And a multimodal prevention strategy is yet to be formally adopted as routine practice within the spinal community. And the unit of authorship, it's a tertiary referral centre serving a population of approximately 665,000. And following a spike in infection rates in our unit, an audit of practice was undertaken, and this demonstrated an infection rate of 8.5%. So following this, an MDT review took place of local practice. And the review panel consisted of the pediatric spinal surgical team, the anaesthesia team, an ID consultant, and an infection control advanced nurse practitioner. And this resulted in a proposal of a series of interventions aimed to minimise infection. Now, just a word on the Public Health England definition of surgical site infection. It basically breaks it down into 3 definitions. So a superficial incisional infection only involves the skin, subcutaneous tissue. A deep incisional infection involves the fascial or muscle layers and occurs within 30 days if there's no implant, or 1 year if there are implants. And an organ space infection, fairly self-explanatory, and again within that time frame. And so this is the infection bundle that we came up with, and you can see the 10 points there: preoperative skin decontamination, normothermia, minimization of theatre traffic, regular changing of gloves every 3 hours, and so on. So the purpose of this study was to evaluate the efficacy of a preventative bundle for patients undergoing this complex paediatric spinal surgery. And it was a retrospective review of the surgical site infection data prior to and after the introduction of the preventative care bundle. So in terms of the patient sample inclusion criteria, so complex pediatric deformity and surgical site infection requiring surgical management within 1 year of the surgical procedure. So we're not talking about infections that were managed with antibiotics alone. So you can see that they were excluded, as were patients that we inherited from other units. So where the index procedure was performed at another hospital. The primary outcome measure was surgical site infection rate within 1 year of the index procedure. So as said, this was a retrospective audit evaluating the rates following the introduction of the bundle. So in terms of results, pre-bundle, 21% of patients developed surgical site infection with a mean age of 10.6 years. Now, out of those, only 4 mandated return to theatre, giving a rate of 8.5%. And you can see the case mix there. The syndromic and neuromuscular patients comprise around 50% of those cases. However, following the introduction of the bundle, 135 complex paediatric procedures were performed which actually met the inclusion criteria. And of those, 3 out of those 135 developed surgical site infection. And this was represented a 2% infection rate, which we found to be significant. And so we found that we reduced the rate of infection to a level commensurate with figures in the reported literature. A recent systematic review and meta-analysis quoted around 3.1%. And this affects improvement in surgical outcomes in terms of costs and morbidity for the patients. And as said, the neuromuscular and syndromic cases formed around 50% of the cases. And so, in conclusion, we demonstrated a significant improvement in the rates of SSI in paediatric patients undergoing complex deformity surgery following the introduction of a preventative care bundle. And we recommend the routine use of this multimodal approach to reduce this potentially devastating complication. Thank you very much, and happy to take any questions.
Tab to start them.
Do you want to introduce them, Neil, or just play them?
Sorry, Lee, just play them, run through. I don't have a tab to do it. It's
okay. So the next talk is paper 112.
Yeah, just run through the next 3 in one go.
Yeah, okay.
Hello, and thank you for this opportunity to present this quality improvement project looking at minimizing the need of HDU support in adolescent idiopathic scoliosis surgery. My name is Devashish Das, and I am an orthopedic registrar at the Robert Jones and Agnes Hunt Hospital. I have no disclosures to give, and no funding was received for this project. Configuration of scoliosis surgery and services have been centralized to specialist spinal units to optimize patient outcomes. As part of this, in 2008, the BSS published guidelines on standards of care for patients undergoing spinal deformity correction and mandated that pediatric patients require pediatric intensive care to be available. However, this was superseded in 2013 when NHS England differentiated between type 1 and type 2 facilities and said that children without significant comorbidities who do not require ventilatory support could be managed in a type 1 facility. In 2016, we developed a multidisciplinary scoliosis pathway with our anesthetic and pediatric colleagues and changed our practice from an unselected pediatric patient cohort to a selected cohort of patients who we felt suitable to undergo AIS surgery at our facility. The primary aim of this project was to assess if patients could be managed safely on a ward instead of HDU in a carefully selected cohort of AIS patients. Secondarily, we wanted to see if it was more efficacious than our previous practice. Prior to 2016, we'll call this the HDU group, patients were discharged from theatre to HDU, where they were admitted for approximately 1 to 2 days and had patient-controlled analgesia administered. The ages of these patients ranged between 3 to 17 years of age, and they had a variability in the ASA. Post-2016, patients were discharged from paediatric recovery to the paediatric ward. Ages for this group were in the adolescent range between 12 to 17, and only patients with an ASA of 1 or 2 were admitted for surgery. All patients were managed with oral analgesia only, and this pathway was developed with our anesthetic colleagues. As can be seen here, the demographics between the two groups were similar. Our HDU cohort had one complication in it, who required transfer out of hospital to another unit due to a pneumothorax. Length of stay was 7.4 days. With the paediatric ward-based patients, there were no complications and none have occurred to date since our change. There was significant improvement in terms of length of stay with a reduction to 5.8 days, and there was not a significant increase in opiate requirements with our change in analgesic regimes. Pain scores at all time points had significantly improved in our change in analgesic regime management. Gabapentin was administered the night before, and intraoperatively a provision of ketamine, remifentanil, diamorphine, and NSAIDs was provided. We also used large volume analgesia with ropivacaine, 3 ml per kilogram, administered at the beginning and end of the procedure. This was based on weight. We also found there are significant cost benefits, with patients with a HDU bed costing £1,132 per day and spending at least 1 to 2 days in HDU, whereas on the paediatric ward, a day on the ward cost £563 per day. This meant that we had a saving of approximately £2,000 per case. In conclusion, carefully selected AIS patients can be safely managed in a type 1 facility on a paediatric ward. It also avoids the risk of cancellation due to sharing HDU beds with other specialties. We found a reduced length of stay and a significant cost benefit improvement. Thank you.
Hi, I'm George Mackay. I'm here to present some work from fellowship at Westmead Children's Hospital in Sydney with Andrew Cree. I'm currently working as a consultant spine surgeon at the Royal Orthopaedic Hospital in Birmingham and Birmingham Children's Hospital. The title of our work is Vertebral Body Tethering in AIS, a prospective look at early intraoperative radiological and patient-reported outcomes in a single surgeon series. We've got no conflicts of interest. VBT is an emerging surgical technique in the context of deformity in the skeletal immature, as many of you know, and it may have a role in selected patients allowing modulation of growth whilst preserving mobility. The best evidence to date comprises of level 3 studies, however the majority of studies are small cohort studies and case series. The aims of our study were to examine the early intraoperative experience of a single surgeon in order to inform our future practice as well as to contribute towards the available data. We analysed initial outcomes, which were radiological, clinical, and patient-reported outcomes in the form of SRS-22. This is the largest piece of work in Australasia pertaining to VBT to date. The initial 14 consecutive patients with EIS undergoing VBT were enrolled. Pertinent intraoperative data were collected alongside radiological parameters, both preoperatively and postoperatively, at a mean of 11.1 days following completion of surgery. Clinical outcomes in the form of the SRS-22 were obtained preoperatively in all patients when available postoperatively in 10 at a mean of 157.4 days following completion of surgery. Our cohort comprised of 13 females and 1 male, with a mean age at surgery of 12.9 years, and in terms of skeletal maturity, an average of 0.86 in the Risser classification and 3.7 in the Sanders scale, with a range of 2 to 7. 6 patients with Lenke 1 curves underwent selective thoracic tethering with a mean of 7.7 levels, and 8 patients with Lenke 3 curves underwent double tethering with a mean of 11.5 levels, a week apart, with the lumbar curve being addressed first. This photograph shows our thoracoscopic assisted technique with 3 small incisions, slightly larger than normal portals, but you'll notice that no accessory portals were required. And this is a photograph showing the thoracoabdominal approach to the lumbar spine with a small incision placed. So it's worth noting that no annulotomy or discectomy was performed in any of the approaches. This graph shows the change in thoracic cob in the selective thoracic tether group was 46.7 to 29.8 degrees, and in the lumbar non-instrumented spine in this group, the change was from 27.8 to 15.3 degrees. In the double tether group, the thoracic spine changed from 45.1 to 16, and the lumbar spine from 44.9 to 12. This is a radiograph showing an example of a 13-year-old Sanders 3 T6 to 1 L1 tether, with a change of 54 to 21 in the thoracic spine and 20 to 12 in the lumbar spine. Some clinical photos showing the change in standing posture of this patient and the bending profile with a change in the angle of trunk inclination. The mean blood loss was available in 13 patients. In the thoracic group, this was 515 millilitres, with figures skewed due to one outlier. This patient underwent extensive bleeding from a vertebra. The median value here was 250 mils, and in the lumbar spine, the mean value was 207 mils. The mean length of hospital stay in the thoracic group was 7.8 days, and in the double tether group 16.4 days. Worth noting that patients remained inpatient between stages. All patients were independently mobile and had 0 to moderate pain at rest and mild to moderate mobilising. SRS-22 scores were obtained from each patient preoperatively, and post-op scores were available in 10 patients at 157.4 days following completion of surgeries. This is shown in this graph. Although the numbers are small and few conclusions can be drawn, it's worth noting some trends in the self-image and satisfaction domains, with an improvement overall here and a reduction in the score in the mental health domain. At the time of submission, there were no unplanned returns to theatre or implant failures at a mean of 170.5 days, the date of which was taken as the 1st of September. And one patient from the selective thoracic group required further tethering of the lumbar curve for progression 10 months after the initial procedure. In conclusion, we demonstrate that there's an improvement in core measurements in both thoracic and lumbar spine in both groups. Our risk profile and complication rate remain low, and we accept that few conclusions can be drawn given the small numbers. At this stage, there doesn't appear to be any clear trend in the overall SRS-22. Moving forward, the decision was made to collect information in pulmonary function, transfusion, operative time, radiation exposure, T112, T1S1 and construct length, sagittal profile, rib pump and shoulder symmetry. Thank you.
Good day, everyone. I'm Dr. Gadia, and I'm going to present a paper on enhanced recovery after surgery in adolescent idiopathic scoliosis, meta-analysis and systematic review. This study was conducted at Queen's Medical Center, Nottingham. The concept of ERAS was introduced by Kellett in 1995, but it was first formalized by Fairham for colorectal surgery in 2005. It involves multimodal and multidisciplinary approach involving physiotherapist, pain management team, surgeon, anesthetist, and specialist nurse practitioners. The common motive of ERAS is to minimize and improve the stress response associated with surgery, as well as optimize the perioperative experience of surgical patients. ERAS has many benefits, of which most important is a reduced length of stay, leading to quick turnover of bed utilization, as well as reduced pressure on waiting lists. It is also associated with reduced complications. ERAS has been shown to be associated with positive patient response, as well as it has a financial benefits on healthcare system. As we know, spinal procedures are associated with high amounts of pain, slow return of function, and prolonged hospital stay. ERAS would likely expedite the return of function and minimize the postoperative morbidity. For pediatric patients undergoing posterior correction of adolescent idiopathic scoliosis itself is quite morbid procedure, and one would question whether ERAS is beneficial in this setting. And hence we reviewed the literature for outcomes of ERAS in patients undergoing posterior spinal fusion in AIS. We performed a systematic review of literature using PRISMA guidelines between January 1999 to May 2020. Primary outcome measures were length of stay, complications, and readmission rates. Studies comparing the ERAS protocol with the traditional postoperative protocol were included in the analysis. After identifying, screening, and applying the eligibility criteria, we found 10 studies that were utilized for qualitative and quantitative synthesis. This chart summarizes the findings of the 10 included studies. It is quite clear that most of the studies were retrospective in nature and were of level 3 evidence, but it is also quite evident that in each of the studies, the length of stay was less for ERAS protocol as compared to traditional protocols. After applying random effects model as well as drawing the forest plots, we found there was no significant difference in age, surgical time, levels fused, preoperative magnitude of curve, as well as intraoperative blood loss. However, we found that there was a significant reduction in the length of stay by about 1.5 days for ERAS protocol as compared to traditional protocols. There was no significant difference in complication and readmission rate. On performing qualitative synthesis, we identified that each ERAS protocols in each of the studies were divided into preoperative, intraoperative, and postoperative elements. The preoperative elements were directed towards educating patients and family about the perioperative experience, as well as optimize the general condition of patients. Intraoperative protocols were directed towards having a specific anesthesia protocol so as to reduce the postoperative morbidity and stress response, and also to adapt the techniques that will reduce the surgical time and minimize the blood loss without compromising on the outcomes. Postoperative measures were directed towards reducing the requirement of analgesia as well as facilitating early recovery. Patients were considered for discharge if they were able to ambulate independently and were able to tolerate oral food as well as analgesics, and were able to pass flatus. Periodic follow-up was set up between surgical nursing and physiotherapy team in order to keep a close watch for the postoperative outcomes. To conclude, this was a systematic review of 10 level 3 or level 4 studies. In this systematic review, we found that ERAS protocols were associated with significant reduction in length of stay without any significant difference in complication and readmission rates. We were also able to summarize the elements of ERAS protocol utilized in various studies, which would serve as the foundation for the further prospective randomized controlled trials on this topic. Thank you.
Okay, so that's the first block, and we're going to take questions on that, those 4 papers. We have no questions coming through, so if I can encourage people to ask questions. Nick, I've got a question for the first paper, which is in a lot of the measures that you put in your surgical site bundle, some might consider were just standard of care. What do you think was the single thing that had the biggest effect on your rate of infection?
Hi, there's play coming over from the final presentation. I can't. I'm getting some background noise here.
Sorry, can you hear me now? Is that any better?
Sorry, the last presentation is just replaying. Can't actually hear the last presentation.
Right, it's not replaying on my list. Ashley, can you see anything you can stop?
There's nothing playing in the background. The problem is there is sometimes a loop on some people's PCs, and we don't really understand why, I'm afraid.
Okay.
Nick, can you hear at all?
I'll try. Yeah, sure. Sorry, can you repeat the question?
We can hear you. So the question is, which of the measures that you introduced did you think had the single biggest effect?
Okay, yeah. So I mean, we didn't drill down on each individual one, but the message that we were trying to push was that it is an infection bundle, and that the cumulative combined effect of all of those things put together that we really thought made the difference. We didn't do a sort of sub-analysis on each individual one, but that was the message that we were hoping to deliver today.
Okay.
Neil, we've got a question from Tom Schlosser.
It's not coming up, Ashley, on the system.
Do you want me to read it?
Yeah.
It says, "Thank you. It's to the last presenter regarding the enhanced recovery. Do you think that a decrease in the length of stay reflects an increase in oral opioid use, especially in children? We would like to avoid prolonged opioid use after discharge."
Thanks a lot. That's a very excellent point raised. To be specific, in all the studies that were included in this analysis, most of the studies they highlighted the point of reducing the use of opioids and starting early NSAIDs in the form of ketorolac. In fact, in a couple of papers, the ketorolac was started as early as post-op day 1 itself, and hence there was no emphasis on increasing the opioid. If in fact, one of the prerequisites for the discharge criteria was a patient being shifted on the oral NSAIDs before discharge. I hope that answers the question.
Does the routine use of non-steroidal in spinal fusion surgery concern you? That's not our practice in our unit, to send people home on non-steroidals.
Yes, that's again very important point, Mr. Oxborough. But going back again, I'd like to reflect in the papers, in fact, the papers by Flesher. They did mention that ketorolac, and it has been widely established in the literature as well, ketorolac does not affect the rate of fusions in the orthopedic surgery.
Okay. Question from Mike Grevitt. This is regarding VBT. Was there any consideration of the curve flexibility in the decision to proceed with VBT? Alternatively, is there a COB magnitude beyond which VBT could be discounted?
Can you hear me?
Yes.
Yeah, good, thanks. Sorry. I don't know what's happening with my camera. In short, no, there wasn't any sort of barrier progressing to VBT in the case series. In fact, if you look at the data in our single tether group, there was one patient who had a fairly inflexible curve. And actually, that's, if you look at the outcomes, you'll see that the single tether group have a slightly disappointing overall magnitude of correction compared to the lumbar group, and that's probably borne out because that single patient had a large 60-degree curve that was inflexible, and we were only able to correct down to about 40 degrees. So I think moving forward, that certainly should be something that is looked at, because a lack of flexibility means a degree of residual deformity.
There's no questions for the paper on ward HDU, but maybe I could ask one. Which was, did you have any handle on whether the patient experience was improved by sending them back to HDU, to the ward rather than HDU, and whether the staff liked it? We found a significant improvement. I think the ward staff like it and the patients like it better.
Obviously, the patients were young adolescents and therefore had their family available to them on the ward. So it would be expected that they would have an improved patient experience, the fact that they can have their parents with them after the operation in quite short order, which wouldn't be available to them if they were discharged to HDU. We've not had any complaints as such or worries of patients not being taken to HDU post-operatively, but we didn't look directly to see whether or not there was a patient satisfaction increase in that, to be fair.
Can I ask a question as well on that subject? We've been doing this for quite a while now, and one of the rules that we have is that there has to be an extra member of nursing staff on the night shift. So that's a sort of provision to sending them back. Do you have any similar rules?
Yes. Set up in Oswestry, we have at least 2 nurses on the ward at night, because it's not just spinal patients they look after. So we have regular orthopedic paediatric patients there as well. And the registrars also do a ward round at night of the ward to ensure everything's in safe order and they don't have any queries or concerns. And the paediatric spinal consultants are available even at night if need be, if there's any concerns or queries. So yes, it's well set up, and the patients are well protected even at night time in our units.
Excellent, because I think these safety aspects are really important to get across if you publish this data. Otherwise, people just think, we can just do it, whereas really you've got a few other things going on in the background as well.
Absolutely.
Thank you.
Thanks.
Okay, so that draws an end to those 4 papers. I'd like to thank the speakers. We'll move on to the next 4, which will be presented by Ash.
Okay, thank you. Just George, can you answer Adrian's question in the chat? There was one last question, but we should move on. So we're going to take the next 4 papers, starting with one that's, I suppose, a very similar topic to the previous one. So we're going to go through a paper on reducing dependency on critical care, 2 papers from Adrian Gardner on using ISIS-2, and then final paper from Tom Schlosser looking at sagittal alignment. So we'll run all 4 papers and then take some discussion afterwards.
Morning. I'm presenting our study on reducing dependency on critical care support in AIS surgery, a criteria-based pathway, a study done at Queen's Medical Centre, Nottingham. I'm sure all of us would have faced this dilemma where our elective scoliosis surgery get cancelled because of lack of critical care beds. But the question that we need to ask ourselves is whether every AIS patient needs critical care support postoperatively, and are there any criteria or guidelines that help us make that decision? To answer that question, we devised an adolescent scoliosis pathway. It was based on a predictive scoring system reported at another center. The pathway defines the level of care which would be needed for a patient post-operatively. The pathway is based on 4 criteria, 2 being the pulmonary function test, the thoracic cob angle, and the extent of surgery by the number of levels being operated. There is a score of 0 to 2 for each criteria, and if the total score is 3 or less, then the patient is suited for a ward. 4 or more would suit them for intensive care. There is intraoperative physiological monitoring, postoperative recovery checklist, and defined strict escalation criteria with a wholesome team approach with the pediatric anesthesia and a spinal team support for the postoperative care. Thus, the aim of the study was to assess the outcomes of this predictive criteria-based pathway for ward-based care for AIS patients. We studied it in 2 cohorts. In the retrospective cohort, we studied 54 patients conventionally treated in critical care, but we calculated their predicted score and also established the actual level of care they received based on their perioperative charts. We piloted the same in 12 prospective patients to define the predicted destination and prospectively correlate that with any need for escalation if needed. The blue bar represents the patients who actually needed ward-based care, and the yellow bar represents those who actually needed critical care-based support. From those who were predicted to go to critical care, only 30% needed critical care level of support. The rest 70% could have been managed with ward-based care itself. On the contrary, those who were predicted to go to ward, only 5.9% needed some sort of escalation to critical care, and most commonly that was due to either any physiological intraoperative neuromonitoring alerts or excessive blood loss, and an aspect which could not have been predicted preoperatively anyways. The rest 94% were suited to be treated with ward-based care itself. In the prospective group, of the 12 patients, 10 were predicted to go to ward, none needed escalation, and those 2 who were predicted to go to critical care also did not need escalation to critical care level and were actually treated in the ward itself. Thus, all 12 prospective patients were treated with ward-based care. That gives us a negative predictive value of 94% and a positive predictive value of 30%. What those numbers mean is that of 100 patients who are predicted to go to ward, 94% would be suited to be treated in the ward itself. Only 1 in 16 patients would have any untoward or unplanned event which would need critical care escalation, which can be easily dealt with the predefined escalation criteria. A positive predictive value of 30% means that of those who are predicted to go to intensive care, only 30% need intensive care level of treatment. The rest 70% are actually suited to be treated in the ward, which gives us a good element of safety. What the pathway does is it gives us a guideline and a confidence for every clinician to be able to pursue ward-based care for these patients with an affordance of a good margin of safety to pick up any deterioration and escalate accordingly. Secondarily, it minimizes cancellation and the burden on our critical care colleagues, reducing the cost of care and improving the overall patient outcome and performance. We are prospecting the 2-year data to come out sometime this year, and adaptation and replication of the pathway in other centers would definitely give further insights into reproducibility and further validation of the results. Thank you.
Thank you. This talk is a 3D cluster analysis classification of adolescent idiopathic scoliosis using spine and torso parameters, presented by Adrian Gardner with thanks to my co-authors, and is from the Royal Orthopaedic Hospital and the University of Birmingham. There are many different descriptions of the three-dimensional nature of AIS. The most well-known is that of Lenke from 2001, but there are others, including the Peking Union Medical College system and the use of the Da Vinci view and more complex mathematical modelling, to name but a few. However, they all concentrate on the spine only. As has been recently highlighted, there is the forgotten third dimension of scoliosis, and that is the axial plane, both of the spine and of the torso. The aims of this study were to examine the subtypes of adolescent idiopathic scoliosis seen when looked at through the measures of the spine and of the torso, namely scoliosis, kyphosis, and torso asymmetry. This was an examination of convex to the right thoracic curves collected using ISIS-2 surface topography. Cluster analysis was undertaken using the amount of scoliosis, which is known in ISIS terminology as lateral asymmetry, kyphosis, which is known as the kyphosis angle, and torso asymmetry, defined as the absolute sum of maximal skin angles over both the left and right sides of the torso. As expected, most images were from females with a mean age of 15 years. The mean value of scoliosis was 27 degrees, mean of kyphosis at 30 degrees, and a mean of the sum of skin angles at 15 degrees. This three-dimensional plot shows the data and the 95% confidence ellipsoids for the clusters in different colours. The number of clusters in the data was arrived at using the statistical elbow method. This table demonstrates details of the different clusters. The easiest way to follow this is the narrative description seen on the right-hand side, where the clusters are described in terms of mild to marked scoliosis, hypo or normal kyphosis, and moderate to marked asymmetry. This is an example of cluster 1 with ISIS-2 and clinical images, and it is would be described as mild scoliosis, hypokyphosis, and moderate asymmetry. Cluster 2 is mild scoliosis, normal kyphosis, and moderate asymmetry, but noting that the area of greatest torso asymmetry is on the concavity of the scoliosis and not the convexity. Cluster 3 is marked scoliosis, hypokyphosis, and marked asymmetry. Cluster 4 is marked scoliosis, normal kyphosis, and moderate asymmetry. And cluster 5 is marked scoliosis, normal kyphosis, and marked asymmetry. In conclusion, there are 5 subgroups of thoracic curves when assessed using measures of both the spine and torso. Of note, the ISIS-2 assessment and thus this subdivision is entirely automated, and using machine learning techniques has been shown to be 94% accurate. This work will help us to take a more holistic view of the assessment of AIS using both the spine and torso deformities that are seen in clinical presentation. Thank you. Thank you. This talk is titled, What does a diagnosis of AIS and Schumann's kyphosis do to the coronal and sagittal balance of the individual, and is presented by Adrian Gardner with thanks to my co-authors, and is from the Royal Orthopaedic Hospital and the University of Birmingham. Part of the clinical assessment of the spine is the assessment of the position of the head over the pelvis in both the coronal and sagittal planes. The distance of coronal and sagittal offset is defined as the horizontal distance from the midpoint of the sacrum from a plumb line dropped from the vertebral body of C7. The aims of this study were to define the range of normality for the coronal and sagittal offset for those without spinal deformity, to define the range of coronal and sagittal offset for those with AIS, both pre and post-operatively, and to define the range of coronal and sagittal offset for those with Sherman's kyphosis. This will provide normative data and assess the effects of two types of spinal deformity on the coronal and sagittal offsets. This study would use data collected from the Integrated Shape Imaging System 2, otherwise known as ISIS-2, which provides measures of both coronal and sagittal plane, labelled coronal and sagittal imbalance. In this study for analysis, there were 829 images for those without spinal deformity, 289 pairs of preoperative and postoperative images for those with AIS, and 59 images for those with kyphosis. None of the kyphosis group had been operated on. As seen, the mean scoliosis was 58 degrees in the preoperative AIS group and 21 in the post-op AIS group. Kyphosis was a mean of 34 degrees in the normal group, 33 in the pre-op, and 24 in the post-op AIS group, and 68 in the kyphosis group. For coronal offset, all groups had a small value as seen, between 2 and 6 millimeters. The sagittal offsets were between a mean of 12 and 26 millimeters. This image is illustrative for the following plots and describes the 95% confidence ellipse cone made by combining the coronal and sagittal offsets for the groups. The following images are to be viewed from a bird's eye position, i.e. top down. This plot shows all of the data. Red is those without spinal deformity, green pre-op AIS, blue post-op AIS, and purple kyphosis. Each dot is a data point and the ellipse is the 95% confidence interval for that data. The box and whisker plots are the data in that axis. Significant statistical differences were seen as shown in yellow between normals and pre-op AIS and post-op AIS, between pre and post-op AIS, and between post-op AIS and kyphosis. However, with the individual points removed, the means and 95% confidence ellipses can be seen. All mean values of all groups are within the 95% confidence ellipse of all groups. Whilst there is a statistical difference, there is not a clinical difference, and the 95% confidence ellipse can be seen as the minimally clinically important difference, or MCID. The range of normality has been demonstrated. Spinal deformity does not lead to a clinically relevant change in the position of C7 over the sacrum in these groups. In conclusion, compensatory change in spinal shape maintains a normal coronal and sagittal offset despite spinal deformity. Thank you.
Good afternoon. My name is Tom Schlosser, and today I would like to present the results of a study we did on the sagittal profiles of different stages of AIS. And for this study, we collaborated with the team of Sukun Shah in Delaware and the team of Kariman Abelai-Genevois in Lyon. As we all know, AIS is a complex three-dimensional deformity in which the lordotic deformation of the apex is together with the axial rotation and lateral deviation part of the three-dimensional deformity of the spine. So as you can see here, the thoracic area, apical area is lordotic in AIS, while the junctional zones in between the curves are more or less straight. So from the other side, the thoracic apical area in AIS is lordotic, while the junctional zones are more or less straight. The local apical lordosis in AIS can influence the global sagittal profile, and in this way it has an impact on the representation of the shape of the curve on the lateral X-rays, and this is often represented by a regional hypokyphosis. 2 years ago, the team in Lyon introduced a classification of the sagittal patterns in AIS. And in this classification, they differentiate 4 different types of sagittal patterns. Type 1 represents the patients with a normal kyphosis. Type 2A, the patients with a thoracic hypokyphosis. Type 2B, the patients with a combination of a thoracic hypokyphosis with a thoracolumbar kyphosis. And the patients with type 3 are the ones with a long lordosis from the lumbar area going up to the thoracic area with a cervicothoracic kyphosis. So in their validation study, they used preoperative AIS patients with severe curves, but to date, we have no idea what the sagittal patterns are of the earlier phases of the disease. So for this reason, in this study, the aim of this study was to define whether this change of sagittal alignment of the thoracic spine in AIS is already present in the earliest phase of the disease. And for this reason, we compared the lateral X-rays, the sagittal profile on the lateral X-rays of 192 mild AIS patients, that's 10 to 20 degree curves, 250 preoperative AIS patients, and 150 normal children who had full spine X-rays without scoliosis. We also measured the conventional parameters such as the C7 slope, the level of the apex and the inflection point, and the thoracic kyphosis and thoracolumbar angle. These are the results. So in the controls, 94% of the children had a normal kyphosis, while only a few had an abnormal sagittal pattern. In the mild AIS, 35% had a thoracic hypokyphosis, especially in the primary thoracic curves. Almost half had a hypokyphosis, whereas in the primary lumbar curves, only 6% had a hypokyphosis. So in the severe AIS curves, also in the primary thoracic curves, half had a thoracic hypokyphosis. In the double thoracic curves, we also observed the type 3 pattern of the long lordosis with a cervicothoracic kyphosis. And in the primary lumbar curve, so the Lenke type 5 and 6, we observed the pattern of a hypokyphosis and a thoracolumbar kyphosis. So, in summary, more than half of the mild thoracic curves of 10 to 20 degrees already have an abnormal sagittal profile. We also compared the conventional parameters between the primary thoracic and the primary lumbar curves, and we observed that the thoracic kyphosis was smaller in the primary thoracic curves, and also the apex of the thoracic kyphosis was higher in the primary thoracic curves compared to the primary lumbar curves. So they seem to develop in a spine with a higher apex of thoracic kyphosis and a smaller thoracic kyphosis. In conclusion, specific pathological sagittal patterns are often already present in AIS at the earliest stage of the disease. Those are rare in the normal adolescents, and sagittal malalignment is therefore a key factor in the development of AIS, and also at an early stage, treatment of AIS should address the sagittal pathological patterns of the disease. Thank you.
Okay, thank you. It doesn't seem as though we've got any questions in the chat room, so I get to start. So a quick question to Siddharth Shah. You developed a policy based on something that you got from somewhere else, which was quite complicated based on number of levels and Cobb angle and diagnosis, and yet quite a few of your patients that you predicted would need HDU didn't actually need HDU. Have you modified your model in any way? Have you worked out the factors that would need to be modified?
So, yeah, that's it. The prospective group at that point just limited to 12 patients. It was a very small cohort. It was in the time where we were still fine-tuning and refining the exact pathway, which we has eventually set into motion, where it has been adapted over a period of 2 years, which we are finishing at the end of this month. So over time, we have been able to have strict criteria as to which patient requires which level of care, including exact criteria as to what defines an escalation to what level, with the 3 different teams who are actively involved with nursing, pediatric, anesthetics, and the spinal team who are together taking care of the patient on the ward where there's a one-on-one nurse to take care of the patient.
Okay, because as time went on, we took away the number of levels and the Cobb angle, and the only patients that don't go back to the ward now are the syndromic patients and the neuromuscular patients. So have a look at those.
Absolutely.
Neil?
Can I ask a question just of the final paper on sagittal profile, just as to be one of the older ex-members of the Leeds group originally, just to point out that back in the 80s did an X-ray study, and they showed that you could, focal lordosis seen in some of these patients actually comes before any signs of scoliosis, and you can predict which patients go on to develop that. So that's interesting observation.
I completely agree that it's more or less impossible to make an X-ray before the start of scoliosis, so we can only detect it at the earliest phase of the disease, and that's the results are definitely in agreement with the older Leeds studies.
Well, that's exactly what the Leeds group did. They did a screening study in schools that set a deliberately very low threshold for referral for an X-ray, to include a whole load of normal kids that were then followed up for 5 years, which I kind of question the ethics of, but that's how they got around that.
Yep. Can I ask a question of Adrian? You're quite lucky, Adrian, because both of your moderators have a past history of doing surface topography of various different systems. Does the ISIS-2 still use markers, skin markers, is my first question. And my second question was around the analysis of your data, because you've put all the curve types together and you've put them right and left. Do you think you might get a different answer if you separated out your single and your double curves and put them convex and concave? Sorry, 2 questions.
So the ISIS system is still marker. There is a new system that will be developed that will be marker-less, but it's in the computer modelling stage. As to your second question, I think you're talking about the second paper with the balancing and the ellipses, because the first paper is just right convex thoracic curves.
Yeah, it is the second paper. Yes, that's right. Okay. Yes.
So I specifically put all curve patterns together, and I've only presented that because when I subdivided it, which is in the paper that's published for that, it made no difference. So I have looked at it. You can't fit it into 5 minutes.
Okay, thank you. Anybody got any other questions? Neil, anything?
There's a question from Mike Revitt to Thomas Schlosser. Does your data suggest we should avoid the statement that posterior spinal fusion flattens kyphosis and avoid SPOs to avoid this?
That's a good question. Of course, we only studied the preoperative profiles in the study, but it seems that a major part already had an abnormal sagittal profile from the beginning of the disease, and not only just preoperative. So whether we should restore it to a normal profile, so a normal kyphosis, or to their original profile when the disease started, we don't know. But probably for the pulmonary function, it's best to restore the kyphosis, and for the lumbar discs. So that's the most common reason to recreate kyphosis, but it's probably not restoring them to when they had a 10-degree curve.
Tom, can I ask another question as well? You talked at the end of your talk about trying to correct the hypokyphosis at an early stage in AIS. I presume what you're trying to do there is to reduce the risk of progression. And there's a bit of talk now about sagittal plane when you're bracing. And of course, it's always been popular in scoliosis-specific exercises, which you'd have to bear with us. We're not very popular in the UK.
So most non-operative treatments for AIS are lordosis type of treatments, so they are not kyphogenic. I think we may need to create some therapies that already address the hypokyphosis in the smaller curves, so even in bracing or an exercise therapy. But potentially to also derotate the spine, you might need some lordosis first to derotate, and then you need to kyphose.
Thank you. I presume you've got some ideas on that. You're going to share them?
Sorry? Yeah, so
you got ideas?
Yeah, we have some ideas. We are now using 3D ultrasound for scoliosis assessment in clinic. So patients only get an X-ray at their first appointment in the outpatient clinic, and then we only do the follow-up by the three-dimensional ultrasound of the spine, which is based on the spinous processes and DPs. It's like a so sophisticated surface tomography. But in that way, we are also now doing analysis of patients that are in their shrub type position compared to their normal position to see what the exact sagittal effect is of those exercises.
One further question from Mike to Adrian. How does your cluster classification sync or not with Albelin-Genevois' sagittal classification?
I think the capital letters say it quite well. It doesn't at the moment, and it's ongoing work to look at what it does tell us and how predictive it is moving forwards. The difference is that it does include the torso rather than just the spine, and that's the difference in the two bits, particularly where scoliosis surgery has an element of removing the rib hump. But it's absolutely right, it doesn't.
I'd like to ask whether me and Ashley can transfer our head collectively to you from banging our head against the brick wall with surface topography for the last 25 years.
A small fee, I'm sure.
I think there is a link between those two studies. We always talk about sagittal alignment, but there are three different ways of sagittal alignment. So that's the surface tomography and the sagittal shape of the spine, or the global alignment or the global balance. There's the sagittal profile of the apical area, which you can only see when you do a complex three-dimensional analysis, and there is the representation on the lateral X-ray. And I think the surface tomography more looks at the regional or global alignment, while the X-ray studies are more focused on the local or apical alignment.
I think you muted, Adrian.
I think that's very fair, and it would be wrong of me to suggest that the ISIS-2 surface topography or any other surface topography can give you segmental sagittal alignment.
Okay. Great. Well, that was a very interesting discussion, and thank you to all the speakers in that session. I think we've got another deformity session tomorrow, so hopefully we'll see you all there. Thank you for joining us. And thank you, Lee, for running the session behind the scenes.